Great. Hi, everyone. Thank you so much for joining us. We're Saeed Saab and Stacy Pollack from the Albert Einstein College of Medicine, and along with Dr. Colbert Getz from the University of Utah School of Medicine, who unfortunately couldn't be here today. It's our pleasure to present to you our roundtable virtually on enhancing the validity of scores from the clerkship oral examination. Unfortunately, due to COVID, we were not able to do this live, but we're looking forward to still sharing this information with you, and you're always welcome to contact us via email with questions or concerns. So we have 5 objectives that we would like to accomplish today, which I'm not going to read verbatim to you, but in general, we want to provide you with a simple and short primer on validity principles, and then examples on how to use these principles to develop your own oral examination. And then we will share some practical tips and lessons that we have learned from administering our own end of rotation clerkship exam. So the first question that you may be asking yourself is, why administer an oral exam and put your faculty and students through this hoop? And there are many reasons for this that are cited in the literature. Some are a little bit more obvious than others. Some are backed up by really good evidence and some are not, but we'll go through some of them here. So proponents of the oral examination argue that they encourage and stimulate learning. So in other words, they act as an additional motivator for studying and for studying differently. Oral exams can expose trainees to this different type of format. And this is something that can be seen in surgery, in emergency medicine, and in Ob-Gyn clerkships. As directors of the courses and co-directors of the courses, we can also acquire an additional measure for the summative grade. So in other words, you get another pixel in determining that final summative score that you give the students. You are providing the students with an alternative format for examination, which is great because not everyone is skilled at taking a written exam. You evaluate domains that are not easily captured by written exams. And here we're really focusing on clinical reasoning, and we're going to expand on this a little bit more in the next slide. You enhance the probability of passing board exams in the future. And this is really from studies at the residency level that I'm talking about here, not necessarily at the clerkship exam level. And then you can judge the effectiveness of the local curriculum, which could be really helpful in, for example, programmatic evaluation. So as I mentioned before, in terms of critical reasoning, here we have depicted Bloom's taxonomy on the left and Miller's pyramid on the right. And proponents of the oral exam really argue that this is the meat here, that the format primarily targets higher cognition of Bloom's taxonomy, so things like apply and analyze, and similarly higher level thinking in Miller's pyramid. So for example, in the shows how category, we're talking about things like critical reasoning, problem solving, decision-making, professionalism, and the ability to apply ethical principles. So first, we wanted to review some basic principles of what we mean by validity, because I know we've all heard this term, but the definition is not as straightforward. So what is validity? So the standards for education and psychological testing define validity as the degree to which evidence and theory support the interpretation of test scores. And the concept of validity is something that has evolved over the years, as you can see in this timeline, with different types and different categories. A lot of them are essentially arbitrary, but nonetheless exist. And the current concept of validity really hinges on 5 sources of evidence, which we're going to review in 2 slides. Before we do that, however, we wanted to review some important notes about this idea of validity. So validity is not a property of the test itself. We're seeking validity for the interpretation of test scores and not the actual assessment. Validity is also a matter of degree, so it's not an all or nothing kind of situation. And the proper way to refer to validity is to say scores from a test have some degree of validity. However, you will see in the literature, and you will see people just say flat out, a test is valid or not valid, and that's really inappropriate. Finally, collecting validity evidence really never ends, which can be both exciting and frustrating depending on what side of the argument you're on. So validity today, as I mentioned before, there are 5 categories of validity, and I've listed them here for you. So content, response process, internal structure, relationship to other variables, and consequences. And today we're going to briefly review these categories on validity evidence in terms of what they mean. And we're also going to provide you with some examples of how you may go about collecting this evidence yourself for your own assessment development. So the first of these is content. So content validity evidence is shown by having your exam or instrument items adequately represent the content or domain of interest. So for example, let's say that you're developing a test on pelvic anatomy knowledge, then anatomy knowledge is your construct or your content domain of interest, and your assessment then must reflect the important facets of that construct and not include unrelated items so that your actual assessment is as pure as possible. Note here that this is done prior to administering the assessment, and we will show you a way to map your questions to an exam blueprint later on in the presentation. The next category of validity evidence is response process, and this deals with data integrity and eliminating confounding variables. And specifically, does the performance or responses that you're getting, are they reflecting what the proposed assessment intended to measure? So for example, if you're giving a take-home exam on contraceptive knowledge, how would you know if the exam assessed their actual clinical knowledge or their ability to Google these answers? So this is an example of how you can think about response process. Internal structure validity evidence deals with psychometric qualities of assessment scores, including item scores. This is a little bit more complex, more mathematical. We're going to get into it a little bit. But note that this is a type of validity evidence that you gather after the assessment is administered and is very mathematic. And we're going to briefly touch on it later again in the presentation. Number 4 is relationship to other variables. And this deals with your assessment scores being related to what they should be related to and unrelated to what they should be unrelated to. So for example, do your oral exam scores correlate with the scores on student oral formal clerkship exams, which aim to assess higher level Bloom's cognition, or do they correlate with the shelf exam? Should they correlate with the shelf exam? And those are questions that the answers to which will depend on whether on the goals of your oral exam, we're going to get into, and the number of questions that you have on this on the levels, for example, because a multiple choice exam is maybe testing more factual level 1 sort of understanding questions or basic knowledge questions, as opposed to an oral exam, which is going to be higher order questions. And lastly, consequences. So the last category of validity evidence is important because for medical school, the consequences, for example, of failing a board exam can be huge. So we owe it to our students to minimize false positives, and we also owe it to society to graduate competent individuals. So here we're talking about a relatively low stakes oral exam that we're developing at our own institutions, but in reality, it could also alter the student's summative grade, which could affect their ability to, for example, match into a really competitive specialty or into their Ob-Gyn program of choice. So a question that you might be asking yourself is, do I need to show each type of validity evidence? And the answer to this is no. Some sources are more appropriate than others for a given assessment, and it also depends on the goals and the stakes of the assessment that you're planning. The higher the stakes, and here think, for example, APGO, the more that you should aim for multiple resources of evidence. And if you're using lower stakes assessments, then most experts agree that maybe 2 categories may be sufficient. So far we reviewed ways to increase the strength of oral exams by collecting these types of validity evidence, but we also wanted to touch on 3 threats to validity that are listed in this slide, and also mention how we can combat these. So construct underrepresentation refers to undersampling of the materials in a way that does not allow you to generalize the results. Excuse me, and an easy way to think about this is, imagine if we went to take our APGO exam and we had 1 case on contraception. Can you really board someone based on that? That would be an example of construct underrepresentation. Construct irrelevance variance refers to variations in scores that are unrelated to knowledge, but are actually related to other factors such as gender, perceived race, language fluency. So that's something else to watch out for. And lastly, overrepresentation of simple recall questions refers to the fact that more often than not, oral exams have higher proportions than you might perceive of lower level simple recall questions, which maybe are best tested by a multiple choice exam. So over the years, we have learned that it is better to proceed with structured oral exams as opposed to unstructured oral exams. And we're going to talk about structured exams in the next slide, But an unstructured exam would be something where an examiner is sort of going off the cuff, kind of freestyling questions, whereas structured exams are a little bit more formatted. And I'm going to talk about those on the next slide. So in terms of structured oral exams, this is Stacy's slide, actually. Go ahead, Stacy.
I'm going to ask for, I'm requesting some remote control. That's okay.
Approve.
Okay. So as Said said, there's unstructured and structured oral exams, right? But there really are 4 different types of oral exams, particularly in the clinical setting. There is a clinical type where you're basically sort of asking, there's an interview type where you're basically asking questions. Then there's a clinical type where it's more based on a vignette or a case, and you're asking sort of diagnosis and treatment, getting a little bit higher order. Then there's a cognitive type, which is really more problem solving based on a patient case. So that would be something where there's a progressive reveal, kind of something like that. And then there's the role playing type where someone's the doctor and someone is the patient. And as Syed said, these can be structured or unstructured. And he already talked about some of the free-flowing problems with that unstructured type, where there's variations in the amount of prompting that we might give, or variations based on the examiner's mood, or are they tired, or variation in scoring if there's no set rubric. And by their very nature, they tend to be very subjective. And there has been some research that unstructured forms of oral exam seem to have poorer grading for underrepresented minorities. So that's also something that we want to be cognitive of to limit. And there's also additional evidence that structured oral exams have an ability to assess at least 5 levels on Bloom's taxonomy, maybe taxonomy, and maybe so maybe not the create, but all the others. And so the structured oral exam, you have the same or equivalent tasks. So you're really supplying the same thing. You're asking the same thing of your learners in the same way, under the same conditions, and under the same time constraints. So everyone gets the same amount of time. Think about the APGO oral exam, right? Everybody has the same amount of time, and then ding, it's over and you're done. And so the ideal oral exam, you're really going to have a very objective scoring rubric. You're going to have multiple examining stations, or even a single station is possible. You're going to blueprint the exam based on the content that you'd like. Now, I'm being perfectly honest that in our own clerkship oral exam, we did not blueprint based on content or based on validity. So we're sort of going backwards and doing that now. But our goal for our structured oral exam was to be able to look at clinical reasoning. So the exam was developed with that in mind. And the structured oral exam also needs multiple trained examiners so that they're not prompting and that they're not giving feedback to someone that someone else isn't getting. And you want to have formal standard setting and quality assurance efforts to know exactly how you're grading and what your rubric is. So what's the reality of the clerkship oral exam? This all sounds fabulous. I love, like, you all say, oh, I want that, I want a structured oral exam, but what's really the reality of performing it during a clerkship? Well, we all have limited time at baseline. So we know, as busy clinicians, there's only so much time, and this can be fairly resource intensive. So there's the amount of time that you have to ask of your examiners to pull them away from their clinical time. But there's also the time it takes to develop an exam, to administer an exam, and the time it takes to grade the exam. I mean, if you have 35 students on clerkship and now having to grade all of those oral exams as one person, which I've done, takes a lot of time. There's also the number of faculty that you need to be able to conduct an exam. I mean, our exam, and we'll go over that a little bit later, is about 35 minutes per student. Multiply by 35 students, think about how many you would have to do if you're doing it yourself versus if you had it for the faculty. You also want to be able to sort of have it be protected, that students aren't going to share the information. So the resource of also being able to have that same time that everyone's doing it. You have to have suitable testing facilities, or you have to be able to have enough rooms that can be private. And then there's the cost. There's the cost for some of the resources, but mostly it's the cost versus faculty clinical productive time. And how do we really develop high quality assessments when most of us are not, haven't had any real formal training in writing assessments? And so, the $1 million question ends up being, how do we develop oral exams with a satisfactory level of validity evidence to serve the goals that we have in the clerkship? And, sort of the answer really is, it depends on what your goal is. And I'm going to turn it back over. Do I have one more? Let me see. I think I have another slide here. Oh, so how do we develop this exam in light of some of these principles? I'm going to turn this back. Am I done with my slides there, Saeed?
Stacey, you're actually going to cover, we wanted to introduce at this point our oral exam before I give some examples. So the next slide is going to be speaking of our own oral examination, which let me see if I can advance it. There we go.
Perfect. So what is our oral exam? So just the little bit of practicality about our oral exam. We administer it on the last day of our clerkship. We have anywhere from, let's say, 28 to 35 students per clerkship, and that's divided amongst somewhere between 5 and 8 examiners. We have 2 cases, one OB and one GYN, again, thinking about the content representation. And although there's 2 cases, the cases are progressive reveals, and so they do test more than one topic on each exam. And we have 7 versions of each exam to cover all our, so there's one for each clerkship rotation, and then we sort of repeat them over the years so that we're not continually developing new exams. We may be modifying and refining. Our exam is 35 minutes total. It used to be a little shorter when we realized we needed a little bit of time with no feedback. So it does require training of our faculty not to give that feedback. And lesson learned, we actually graded as a team immediately following the conclusion of the exam morning, which has the added benefit of getting it graded quickly. So we can get those numbers back so we can get our summative assessments back for our students in a faster manner, that it's not too labor intensive for one person to grade, and also has the ability for us to learn from each other about what questions worked, what questions don't work, and sort of real-time understanding about sort of which are the correct answers that we want to accept. And it's worth 15% of their ultimate clerkship grade. If you, out of 100%, it's worth 15%, 7.5 for the OB case and 7.5 for the GYN case.
I'm going to jump in for a second to also say that even though we don't give feedback because of the time constraints of that morning, every site director conducts mock oral exams. And during those mock oral exams, we give feedback. So you could design your exam in a different way and say, I'm going to dedicate, instead of 17.5 minutes, my exam is going to be 25 minutes. So in the last 6 minutes, I'm going to review content with the students and give them a little bit of feedback if they had really absurd answers or something along those lines. And that can be obviously modified according to what your goals are and what you're trying to accomplish with this test. We do some of that in the mock oral exam. But again, it can be time intensive.
And again, we'll go a little bit more into the mock oral exam a little bit later. But going back, just adding on, it really depends. Or do you want to use this? Some people, you can use oral exam for formative feedback, not summative feedback. We use it for summative feedback. But if you were using it for formative feedback, which a lot of students really like, then certainly giving that real-time feedback to the learner is important. And this is just sort of a copy of or a sample of our oral exam. This is just one OB case. There's a little vignette. The students get somewhere between 3 and 4 minutes to read it. And that vignette has an HPI, a little bit of their past medical, past surgical, OB history, a little bit of physical exam, a little bit of maybe some laboratory data in there as well. And all students are given that to read. All faculty are given that as well to read. And then the second little tile there is actually our examiner case list. Those are the questions that we actually ask. And the questions we actually do ask our students to date pregnancies. We have them use a wheel. I know APGO does recommend using the app, but there might be times when their phone runs out of battery. So, or maybe you can't get the app for whatever reason. So we do have our students utilize the wheel. We have our students look at tracings and read a tracing. We have our students look sometimes at ultrasound images. And it is a progressive reveal. And we almost always are asking them, what is their differential diagnosis, how they want to come to, what is anything else that they would want to ask in the history based on that differential diagnosis, so that they can use hypothesis-driven thinking, anything else that they would want to ask in terms of physical exam, and then what kind of testing they would want to do. We then kind of give additional answers. We have them come to what they think is often more what they think the real diagnosis is, and what supporting evidence might be there. And then in addition to having the case be a progressive reveal and evolving, we always have within that case other things, because I think it's really important for us to teach our students, and again, getting back to what the goals of our exam is that patients aren't one problem. And so, if they notice that someone is a smoker, if they notice that someone has the suspicion of domestic abuse, or, different things, we want to make sure that they're noticing those things and querying about them, if not for the emergent situation, that eventually before that patient leaves the hospital, or when they want to follow up with the patient, they'll have a discussion maybe about weight loss if they notice that their BMI is 40 or something like that. And then we have a grading rubric that sort of precept. And then again, in real time with our examiners, we kind of go over if we think what was put forth is correct, or maybe we ask for too few questions to be correct, too few of the choices to be correct, or maybe we need to have them give more options.
Perfect. Thank you, Stacy. So now let's cover how you may collect validity evidence in each of these domains prior to delving deeper into the logistics of the exam, which Stacy's going to take over again in a few slides. As we mentioned before, you don't have to have evidence in all of these. Stacy, I think you still have control of the screen, which is switching crazily. Let me see if I can go back here to where we were. When you move your mouse, I think it still moves it around a little bit.
I've given control over to you completely.
Perfect.
As I often do, doctors.
So we want to give you some examples of how to collect evidence in each of these categories. And remember that you don't have to collect evidence in all of them. Some I think are more important than others. For example, I think content is incredibly important. So there are three ways to show content validity evidence. And the first is really to create an exam blueprint, or what we call a test specification, which is what is shown on the table here. So you do this by identifying the content for each learning objective, which is shown on the x-axis, and then you decide on the level of competence for each of the learning objectives at which you want to test. And that's here, Bloom's taxonomy on the y-axis. In this sample here, you can see that this is for an exam that has multiple choice and essays and things like that. For your oral exam, you could use a similar thing and just say, I want 3 questions here, 2 questions here, 1 question here. And then you can compare and ensure that all of your forms have a similar number of questions represented over the different levels. And we've learned from looking at our exams, for example, that our 7 forms are very different. So that's why we're trying to go through it. Then you can determine, like I said, the number of types of questions for each of the learning objectives. And essentially the important part here is that obviously this is done before the students complete the assessment, or in our case, we're retrospectively going back so that we can develop a better assessment. After that, you need to create test items. And this is really an art and a science, and it's difficult. It takes a long time. It takes revisions. And like Stacy said, in our case, so many faculty have sat there grading these exams, and they've provided feedback over and over and over on the question. So it sort of has self-revised. And for content validity evidence to really show this in a manuscript or for your exam, you really need to demonstrate that whoever wrote the items was trained in item writing, and you need to describe that process. And finally, you want to make sure that the items that you choose are appropriate for the learning objectives, and you can either have an expert assign a list of items that you have created to each objective, or you can do the assignment yourself and then have someone else review them for how well they represent the objectives. In terms of response process, there are many ways. I've listed 5 sample ways here in which you can collect validity evidence for response process. But we're going to focus, or just briefly review, the top 2 for the sake of time. So in terms of student format familiarity, after the exam, for example, you can conduct a focus group or an interview or survey the students to ask them about what strategies they use to respond to the items. You could also review, for example, their response time to each of the questions, or you can have what we call a non-knowledgeable person take the exam and see what they score. So for example, if I ask my mother to take a multiple choice exam that I wrote on infertility, could she, using general knowledge, get a 65%, at baseline? And what does that tell you about format familiarity and content? And then quality control of scoring systems is the second one that I wanted to review. And, the next, which, for example, in an oral exam, can be done by providing the graders with a matrix with point values for each question, and then have the course directors or the individuals directing the grading process then double check that information. If you want to read about the other three items here, you can do so in the standards, which I just bought actually, and it's a little bit dry, but I think it's a very good read. In terms of internal structure, there are three sources of evidence that I listed here. The first one is reliability, and all of these, by the way, are very mathematical. It's the way that I think about them. Reliability is complex because there are many types of reliability, and for test scores, we usually are referring to what we call internal consistency. And the idea here is that you want items that are measuring the same construct to correlate with each other, and you want that's one aspect of it. But you could also look at it from the point of view of the individuals that are assessing. And if your assessment is rated by multiple individuals, then you would want to make sure that if multiple individuals are assessing one student, that those scores also correlate. So that's another way to think about it. In terms of item analysis data, we frequently use reliability coefficients. This is very mathematical. And if the scores, when you calculate these reliability coefficients, which we're not going to get into, but you can look up, are less than ideal, then item difficulty and item discrimination will help you determine how to improve your assessment in general. And lastly, the last type of internal structure validity evidence that I want to mention is factor analysis. And factor analysis is a statistical procedure to determine if items that are proposed to assess the same construct are sort of hanging together, or if there are more constructs that you're accidentally measuring in your assessment, and therefore it is not as pure as you think it is. This is another one that is pretty easy to show in conjunction with content. So if I were personally going for two, these are probably two that I would value most. There are three main ways to show evidence for relationship to other variables. The first is by correlating assessment scores with scores from similar or dissimilar assessment measures. And think here, to what extent should my clerkship oral exam correlate to something else in my clerkship? So for example, our students give an oral presentation, a formal oral presentation where they then get asked questions and then they turn in the write-up. For us, we think, and we're in the process of analyzing this data, that really that's what should correlate most closely to the oral exam because it's the most critical thinking sort of thing that they do. Should it correlate with the shelf? Maybe. It depends. At what level of blooms is the shelf being written? Compared to at what level are you writing your exam? If you're writing your exam at a very basic level, then maybe it should correlate, but maybe it doesn't, and that's okay. It really just depends. Another way to show relationships to other variables is with criterion correlations. And this, for example, is along the lines of, should your CREOG scores correlate with your performance in residency? Or, for example, should ACT scores highly correlate with college performance since they're supposed to predict college success? And that's a little bit harder because in the clerkship, as you can imagine, what would your oral exam predict in the future? Your ability to match, for example? And that's something for you to think about. And then lastly, before Stacy takes over again, consequences. So there are two main ways to show evidence for consequences. And the first is, if your assessment is high stakes, you have to select the pass-fail score using a standard setting exercise. And that can be extremely difficult in the context of a clerkship. APGO obviously does this, but they also have a lot of resources and money and data points. But once you have a passing score, then you should see how students who pass perform later on compared to students who failed, for example. And this, like I said, this is very complex. At our institution, we don't really fail anyone or pass them necessarily on the oral exam. We give them a score out of 15%. That, however, can determine if they get an honors or a high pass, if that score kind of shifts them around that line but we don't necessarily say, okay, they failed this and give them 0 points. But obviously it can have an impact on their final grade, which can then have an impact on matching and those sort of things. So we just covered 5 examples, the 5 categories, and some ways in which you can collect evidence for those. We also gave you this handout from a publication by Dr. Corbel-Getz on determining the assessment, the utility of an assessment. And part of this scoring system is validity evidence, but it also has multiple other ones. And you have this handout along with Dr. Polak's OB oral exam for one of our blocks. And the one that we gave you is the one that has the highest amount of level sort of 3 and 4 questions, just to show that one. But we have others that I know have less. So we wanted to give you a good example. And again, we're in the process of sort of fixing those. So now Stacy's going to take over and give you a little bit more on the logistics of administration and some tips and tricks related to that.
So again, let's focus on those logistics of administration. So what are the resources that you need? Well, actually, let me back up to say one other thing, which is, I think you did like really a great job about talking about looking at the exam and getting validity. There's also ways to look at the question and how those questions stack up. So often when we take a multiple choice exam, we get all kinds of metrics on exam items. One, I could do that if you did the stats on the oral exam items, depending on how you're grading that as well. But that would be resource high in terms of doing that assessment at the level of a clerkship. In addition, our points of data are relatively low for any given assessment, since we do different assessments for each rotation, purposefully, so that the students don't go in saying, oh, this is going to be an exam on preeclampsia, then they would only study preeclampsia. That's not aiding learning. But now going forward more with the resources. So what are the resources that we need? We talked about, well, we need time for our faculty, and we actually need to get time at a given location. So when we get the location that has enough spaces, we also need to say, can we get the time in those classrooms, right? So we, for our exam, we tend to do it again on the last Friday of the rotation. We have been able to get buy-in from our department to give time to our faculty for that. And the faculty that we utilize, which is another one of our resources, is our site leaders and associate site leaders, and a few other faculty that are very invested and engaged in medical student education. And so we've gotten buy-in from our faculty to free up time for our faculty for that oral exam morning, so that we can conduct that exam what used to be in a sequestered fashion. So we used to have all our students come together. We would do sort of an intro, and then we would have students go into an exam room, one examinee to one examiner. Then they would stay in that exam room for both the OB and the GYN case. And then the students would go into another room where they all would wait until everybody finished, and then everyone would leave together. Well, we learned during the pandemic that wasn't so safe. So we actually have our students either come for our initial meeting if they're in the first group of students that are going to be examined, or they Zoom in for our intro talk, and then they arrive 20 minutes prior to their exam time. And so another resource that we're talking about is the coordination we need to do, and creating that schedule so everyone knows where and when they need to be. And then some of our examinees go into the room, one examiner to one examinee, and then they leave. We still try to keep it, it is a sequestered exam. We don't give out the exam. And we additionally, we also go ahead and our examiners have, I'm so sorry. Go. Yes, sorry, that was my daughter coming into the room, which is what happens when we do this at home. Sorry, now I forgot what I was going to say, so I'm going to go back. I apologize. So in terms of, so our examinees go into the room and then they leave. And so it is actually better for social distancing. It's actually also better appreciated by students, so they don't have a lot of downtime waiting around. It and we can also have the ability to do this oral exam over Zoom with breakout rooms, which we did do during the height of the pandemic when all our clerkships were virtual. And now actually, as the Omicron surge is upon us, we'll be doing that again, our oral exam over Zoom with breakout rooms. And so again, the resources we have at the time that we need, the location that we need, the faculty that we need, the coordination so that everybody knows where and when they need to be, the grading. That grading, by the way, is figuring out the rubric that we need, but also the time to grade, which lesson learned, doing that immediately after the exam by committee is not only time efficient, but also gives us better grading. We're more consistent because we have feedback from each other in terms of standard setting in real time. The training, when you use consistent faculty, the training is less arduous because you don't have to keep training new people. People know exactly how to conduct the exam so that it is less subjective, because the whole goal is to have a more objective method. And then the material resources that we utilize, we have timers for everyone. If you don't have a timer, you can use a timer on your iPhone, but timers aren't too expensive. We have lots of pencils everywhere. I'm a big pencil fan. We have pencils for ourselves. We also have pencils for the students so that they can write out their differential diagnosis. So we help them to be more hypothesis driven in their thinking. We have a clipboard. We also have wheels. Wheels used to be easy to come by, not so much anymore. So we do reuse our wheels. And that's the majority. And then we have a lot of photocopying that needs to be done. So that's another resources. We need someone to help us with that photocopying and that coordination. And that actually is our clerkship administrator. Again, more lessons learned. We really created this exam based on the APGO oral exam model of the structured cases, that everyone was sort of getting the same questions so that we could be as standardized as possible. It's not variable in the level of difficulty. So maybe, Saeed asks a lot tougher questions than Stacey. That wouldn't be fair to the students that had Saeed. So we all get the same questions. And we choose the high yield topics, high yield about what appears on their shelf, high yield in terms of what appears in the office, and high yield based on the learning objectives as set forth by APGO. And so, and we have an expert panel on the consensus for answers, but also an expert panel, which is our teaching committee and our grading committee, which is again, mostly our site leaders, associate site leaders, and clerkship directors. That expert panel also on what are those high yield topics. We repurposed the exam. So there was a lot of work and a lot of time in creating the initial exam, but in rewriting the exam, it's a lot easier because you're refining and you're continually refining based on feedback. As we said earlier, we did not originally map in terms of the kinds of questions or the Bloom's taxonomy. We're going back and doing that now, but it does allow us to have some more standard setting by going back and mapping. And again, we adjust based on real-time experience because we are grading as a group.
And I'm going to add Stacey. When Stacey is referring to standard setting, we're talking about standardization of the examinations, not necessarily standard setting to develop your pass-fail cut point, which is actually quite complicated. And there are many methods that you can use to do that. But we don't do that in our clerkship because of the number of the N, number one, and it's just not high stakes enough for that. We think for our purpose at this point.
And I will say that if you even use like a standard 65%, we don't, and if you look at anything less than 65% as being a fail, which is often, what's used for many multiple choice question exams, people tend to do fairly well in their clinical reasoning skill. So we're lucky that we don't have to we haven't had to fail anyone based on even a failing grade on the oral exam because of that. We're going back and we will correlate it with, as Saeed said, the shelf exam with their formal case presentations and write-ups and their overall clerkship grade. We've done a little bit of correlation, and it does seem to track very well and correlate with the case presentation, which are the things that we have for clinical reasoning. It also tracks and correlates a bit with the shelf exam because there is a certain innate amount of knowledge that you have to have, but it will be interesting to go back and correlate different questions based on Bloom's taxonomy, which we'll be able to do when we do this. We have learned that the format of oral exams is not so familiar and is often scary. And sometimes the limiting factor for students was their just ability to think in that real-time way. And so we do offer mock oral exams, which gives students a familiarity with the format, but also, as Syed mentioned earlier, gives us that opportunity for more formative feedback and learning. We offer mock exams in two ways. One, every student has the opportunity to have their own personal mock oral exam with feedback, but then we also supply students with a video watching someone take an oral exam. I think I interviewed one of my associate site leaders and gave her the oral exam. And so we have that video available so the students can see how the process goes. We have now supply students with a list of hot topics of high yield items that they are likely to see, at least some of them, on our oral exams so that we make sure that they're studying the high yield topics. What's also been an added benefit, and I can say this from giving the clerkship oral exam, but I can also say this as a subspecialty APGO examiner, is that we really learn how to teach better, what we're maybe not teaching so well. So while it is true that learning drives assessment, it's maybe a little true that our assessment is helping us to drive learning so that we can make sure that we are teaching our students the things that we think they need to know and that they can think about things in the way that we want them to be thinking about them. Because sometimes we've been surprised by what our students didn't know when we asked them a question that we thought that they would be able to reason through and they couldn't. We were like, you know what, we need to make sure that our students, one place this came up was in understanding sort of what our initial prenatal assessment is. And what goes into sort of the prenatal record and understanding the importance of the things in the prenatal record, that's kind of driven teaching sessions for us. And so again, like Syed say, we have some handouts for you. We have a sample of our oral exam, including the questions that we ask and the grading rubric, and then this assessment utility rubric as well. One thing I want to point out on our oral exam is that it's a living document, so to speak. It does change as we change things. And so so I will point out one thing is that, you know, it says here, I think it says an African-American female. So we actually wouldn't use that term anymore. And so but we might put it in their, you know, family or social history that they state they're of African-American descent. We wouldn't necessarily put that in our one-liner as we used to. And there's a whole bunch of,
oh, sorry, Stacey. I was going to say that the version we've given you is the non-improved version, so it's by no means perfect. We just wanted to give you an example of what we had been using. But like I did mention, I had already analyzed all of the versions, and I know that this version has the highest amount of higher order, like cognitive questions.
And here's some references just for you to go back if you're so interested. And I know we both want to thank you. And we know this is not the same typical kind of roundtable format, but we hope that you're getting some useful information out of it. And please share with us your feedback. And we're happy to share any additional resources that you might want.
Thank you.